So thank you very much. I want to congratulate last talk by Jorge. It was an amazing talk in the field. So I would like to thank you, all of you, for your coming today here, and the organizer for giving me the opportunity to come. So as you can see here, the title of my talk is somehow informal, but this is a potpourri of practical cases using machine learning in biomedical research. Okay? Can you hear me well? Yes. So I would like to after my talk, you will be understanding why I called this in this way, this title of this talk. So I'm going to speak about practical cases, and the first one is about how we age, could be imprinted in the human brain connectome. So this is something that we have been working already in the lab for the last years. It's about human connectomics and how we could encode aging. So when we are born and then we become teenagers and adults and old people, there are many changes and variations in cells, tissues, organs, also the brain. And we were asking about how brain networks were kind of changing along the lifespan. So when you look into the brain, this is different white matter tracks. White matter tracks is like biggest connections in the human brain. So here I'm plotting their different age in years for different people. Each dot here represents a different person. So you can see here, it doesn't matter to which white matter track you look at. When you represent here R1 parameter, it's just something like telling you how much the integrity of that tract is, so the higher the better. And you can see here that when you are younger, typically there is something that starts to increase, arrives to a maturity level, a plateau, and then it starts to decrease again to the previous young states. No? So this is called U-inverted patterns because it's an U-inverted. And it doesn't matter to which you look, you always have the same kind of patterns. So this is morphology, this is morphometric characteristics of the human brain, but this scale up to cognitive function. When you perform different tasks, it's very typical that you start to make it better, arrives to a plateau, and then start to decrease performance as well. So the motivation of this work is based on several questions. So the first one is, can we use brain connectivity to measure brain maturation? If this is true, there are two concepts of age. One would be the brain connectome age, so the age that can be encoded in that human brain. And the other is the chronological age, so it's the real age that the person has. This is tremendously important because if they are different, which is bigger? So imagine that you have old people in which the connectome age is much younger than real age. That can be very good for that person. But the opposite, imagine a person with 70 years old having 85 years old in the brain, might indicate accelerated aging. In kids, it's the opposite. So imagine normal kids that have connectome age older than the real age chronological might indicate neurodevelopmental maturation, for instance. So second question that motivates this study is, can we alter that age? For instance, by rejuvenation of the connectome age using a treatment or a therapy. Imagine increasing the level of physical activity using a pill, a drug, or a rehabilitation program. So if we could somehow make that brain younger, that'd be very good, or even to test a therapy about pre and post therapy, if you could somehow rejuvenate that brain. And the third question that motivates this work is, if this is possible, what brain areas are those whose connectivity predicts the age? In neuroscientific literature, this is called like circuit correlates. So about possibility of encoding brain maturation in brain connectivity, this is something that already Nintendo did in the 2000 early years. And after you were playing for a while, based on reaction time response, they were kind of telling you how old was your brain. So here, this is indeed something that has been for a while, since the 70s, was the first evidence by Breton, is the father of the modern neuropsychology, and then he introduced the brain age quotient as a measure for age-related cognitive functioning. Then there are other authors as well that have been introducing brain age based on morphological features of the brain, and here we are going to focus on connectivity. So what is brain connectivity then? So brain connectivity is just kind of a matrix. This is just a table of numbers in which you typically represent here different regions of the brain. Here region I, for instance, could be the hippocampus, and then you represent again to the other regions here, J could be the amygdala. And then you could say the connectivity from hippocampus to amygdala is this number. This matrix is called brain connectivity matrix or connectome, and it's telling you what is the connectivity from one region to another in the entire brain. This could be either functionally related to how similar are the dynamics of the different regions, or structurally. In MRI corresponds with the number of white matter tracks that connect one region to another. So then we were using is something which is called hierarchical agglomerative clustering. It's an unsupervised way of clustering data, as Jorge was introducing excellent well before. And then you can work in a hierarchy. So imagine here in the level 20, you will have 20 times 20 matrix, and then you can go down in the tree and get different levels. What we did here was, by fixing different levels, each module was represented, each region was represented by 4 different features, as Jorge was introducing before, which is the internal connectivity, meaning like the regions within that module, the total connectivity. Then external connectivity from that module to the rest of the brain, the total connectivity, and then internal connectivity and external connectivity, also for the functional representation. So doing that way, what we came here was with a regression problem. I'm not going to go into the maths, but I will just try to tell you in what's different. So the total number of subjects in this study was 155. The age was ranging between 10 and 80 years old. And for each of those, we performed triple MRI acquisitions, which is that person going to the scanner, and then you take 3 different classes of images. One is morphometrical, diffusion, and functional, and then we have different features or descriptors. Some people use the other name. And then we have in the tree, we have from one level in the tree to M level to the tree. For each of the modules, we have 4 different features, which are the functional internal connectivity, functional external connectivity, structural internal, and structural external. Then we did different feature selection methods. I'm not going into detail, but it's a way of previously identify a priori what of those features could work better. And then also it's a multiple comparison problem here. This is a regression problem. Jorge was explaining very well in words. So you typically, what you would like to do is here, you put age, real age, t variable, and then you have x variables. It's about connectivity descriptors, and then you would like to learn the weights. Learn means to define a cost function here is the mean square error, and try to get the weights that minimize this error. When you do that, we were performing, as Jorge was explaining as well, cross-validation, meaning like you typically obtain the weights in one data set and test how good is the model in a different data set. And for that, we have a metric, which is the mean absolute error there. So I'm going to show you just results of this work. So this is the brain connectum age. So the age estimated only based on your connectivity, and this is the chronological age. This is test data set, so meaning like these dots here, each one is a different person. They were not used to train the model. So doing in this way, what we can see here is that indeed the connectivity of your brain can encode very well the age you have. So from 10 to 82 years old, we have a mean absolute error of 5 years. So we only are mistaken in 5 years difference. So what is the circuit that predicts most the age is the frontostriatal thalamic. You have some background in neuroscience, so this is a very important circuit that is formed by thalamus, basal ganglia, and frontal areas of the brain. So, is this meaning that the frontostriatothalamic circuit is the only circuit that disconnects with age? The answer is no, because here we have different other circuits that also disconnect with age. Here you see here the hippocampus connectivity to the rest of the brain as a function of the age have a negative slope, meaning that disconnects along the lifespan, but frontostriatothalamic, the slope is bigger, so this connections is more pronounced. So to discuss this first part, brain connectum age is a multi-scale structure and function estimation of the chronological age and can work as good as other brain age estimators using morphological descriptors. Our approach reveals that the circuit participating the most in age prediction is the frontostriatothalamic. We suggest that when studying healthy aging, frontostriatothalamic is the circuit that majorly dominates, but when studying pathological aging, the hippocampus circuit is the gold standard in both human and animal studies. Frontostriatothalamic mediates motor skills, cognitive control, executive function, also regulates dopamine and serotonin release. Discrepancy between chronological age and connectum age might work as a biomarker for quantifying deterioration as a result of disease or improvement after some treatment or therapy. As you can see, this has a limited applications. So this is continuation of this work. Then we come to a population of autistic kids, and we were able to kind of characterize what happens in this brain connectum age in this population. So these are 50 different kids with a autism spectrum disorder and 47 typically developed controls, which is normal kids. So they were recruited into different cohorts, and here we have age, gender, full intelligent quotient, and different parameters characterizing movement in the scanner, and this is the ADOS scale, which is a diagnostic scale for this condition. So then we did the same, which is somehow from diffusion and functional imaging get brain connectivity matrices, and then try to extract different features and do a regression problem here using support vector regression, which is a different class of doing the internal learning of these models, and then represented, as we did before, brain connectum age as a function of chronological age in the normal kids and in the autistic kids. What we found was the following. Here in blue line there, you have what is normal kids behavior. You can see chronological age can be estimated very well from brain connectum age, and this is the straight line here. But when looking to autistic kids, what you have is when they're like younger than 12 years old, what they have is a brain connectum age bigger than the chronological age. This is somehow over-maturation of the brain in these kids. But when they become older than 12 years old, that pattern inverts, and what you really have is a connectome age is younger than the chronological age that indicate the late maturation. So we have trajectories in which there are two patterns that they have like an inflection point in mathematics. So this is the same kind of results, but shown in a different manner. Here you have autistic spectrum disorder, typically developed control, and we have here children younger than 11 years old, adolescents older than 13 years old. As you can see here, how the brain connectome age in kids, autistic kids, is statistically higher than the chronological age. But when you look to adolescents, what you have is that the brain connectome age becomes statistically smaller than the chronological age. And this does not happen in typically developed controls. So and here, replotting connectome age as a function of chronological age, we can see again over-maturation, delay maturation significantly, and this is not happening in normal kids. So to discuss this part, this is the first study assessing brain trajectories of brain connectome age in autistic kids. Autistic kids have significantly higher connectome age than normal kids in the range of age of 6 to 12 years. From pre-adolescence onwards, these patterns reverses, showing that connectome age is lower in autism than normal kids. About what are the brain circuits corresponding to these age trajectories, we found first circuit was the cortical limbic striatum with temporal frontal limbic structures such hippocampus, amygdala, and basal ganglia. That circuit is implied in emotional processing and social behavior. The second circuit was the frontoinsular temporal, implied in stimuli encoding, salience, network, reward, and decision making. Our study shows the possibilities for using connectome age at the subject level single person as a biomarker to quantify the level of brain connectome maturation and their trajectories in other neurodevelopmental, but also could be neurological conditions. So about this potpourri of cases, this is case number 2, is totally different one. This is why it's a potpourri, but are practical examples. I'm going to speak about something that we have been working in the last years as well, and it's about tumor sampling in anatomical pathology. So this has been thanks to my colleague and friend, Professor José Ignacio López. He is professor at the University of the Basque Country and currently is the boss of the pathology service in the Cruces University Hospital. So he came to me with this problem, which is the problem of intratumor heterogeneity. This is really a bottleneck in cancer research, and I'm going to tell you here very briefly why this is the case. So here, tumor heterogeneity has important implications in diagnostics. So imagine here a highly heterogeneous tumor, and then you go for the pathologist. He has to take some biopsy and try to make a diagnosis based on that. So if he takes this piece of the tumor, he will come with one diagnosis that could be different to this one or to a third part of the tumor because it's highly heterogeneous. So imagine that you go for one of the pieces and you get a very low-grade tumor, but in another piece you have a high-grade tumor. This has enormous responsibility for this pathologist, has important implications for this patient and for her treatment. So we came here for the first time and trying to do some kind of modeling of this problem and define what we called divide and conquer strategy, which is something well known in computer science about how to do tumor sampling to enhance the detection of intratumor heterogeneity. So look here, these are renal cancers. This is a very homogeneous one. This is a highly heterogeneous one. And what clinical routine is advising is, depending on the size of the tumor, you have to take different pieces of the tumor and then going into the protein or different staining of different properties of the tumor, and then do the diagnosis. No? So here in a highly heterogeneous one, the big pieces of the tumor has the problem as I was explaining you before. So divide and conquer was kind of, rather than taking big pieces of the tumor, you could do and then take smaller pieces such that the number of paraffin blocks could be the same, but the chances you have to get more intratumor heterogeneity is much higher here than that. Then we proved that this is the case. Here we presented several kind of modeling simulations, strategies, heuristic metrics, and different algorithms to try, when the intratumor heterogeneity was random distributed, the two strategies, routine protocol, taking big pieces of the tumor, or divide and conquer, were totally equivalent. Were equivalent in the mean of the detection, but also in the variance of the detection. So how much variable is your diagnosis when you repeat the same procedure during several times. But if the intratumor heterogeneity is regionally distributed, the amount of detection divide and conquer outperforms the routine protocol. This is happening for the mean, but also for the variance. Here in red, you can see how the variance goes to 0, meaning that that way of sampling the tumor is more efficient, because you will come with the same diagnosis no matter how many times you perform. Then we come with different continuation research, which was about how to implement this in the clinical lab, and then we come with like a multi-site cutting device implements efficiently the divide and conquer strategy, which was cutting and do this performance. We also published about different pathologists were performing the real diagnosis of the same tumor, but performing multi-site tumor sampling, divide and conquer, versus routine sampling, and they came out that by doing multi-site, the number of high-grade tumors was significantly higher, more detected than routine sampling. Also, other properties were also significantly bigger. We wrote here a review in a classical human pathology journal about this strategy and implications at different levels. We also here were extending that possibility to hollow visceral tumors like gastric or colorectal tumors. This is, I'm not an expert in cancer, so, but what I learned here was that in these classes of tumors, there is the outside front, there are invasive front, there are typically more aggressive cells than outside of that front. So we suggested here to use this kind of pasta cutter here, taking different columns of the tumor and repeating the multi-site. And here we were presenting here for different levels of budding. Budding is that mix of aggressive cells and non-aggressive cells coexisting in that invasive front. So tumor budding was detected equally with routine protocol or divide and conquer, but the amount of intratumor heterogeneity was outperforming for the different levels of budding, always the case of routine protocol. Finally, here what we did was modeling tumor formation in different ways, from linear, branch, neutral, punctuated, and we came that multi-site tumor sampling, it doesn't matter at which time point you do the diagnosis, you will be always outperforming routine protocol in detecting intratumor heterogeneity. So this is just to tell you that this is a very important journal in the pathology community, and we came to the pathologists and we could wrote a nice article on this work. So in the potpourri of this morning, this is the case 3. I'm going to explain about other classes. This is, as Jorge was introducing very well, indeed he did the introduction for me. So we are here asking about predicting metastasis in melanoma research. So this has been thanks to Professor Lola Boyano, who is also a colleague and a friend. She is professor at the University of the Basque Country in the Department of cell biology. So the first study we did was trying to predict from protein in serum the metastatic progression of early stage melanoma. So here we have 100 different controls, 348 patients, and you can see here a melanoma was located in different parts of the body, and then we have early stages 1 and 2, 67 cases, 24% of them developed metastasis, and then 3 and 4 stages, there were 3,200 of them developed metastasis. This is why we here are trying to predict metastasis progression 1 year follow-up just from early stage melanoma. So about the methods, so the question we wanted to ask was, can different protein serum levels predict metastasis progression in early stage melanoma? As Jorge was introducing before, this is a classical supervised classification in which we use some well-known levels of the data. We know which patients converted to metastasis, and then we do some training and learn how to predict new patients that go to the clinics. No? So class 1 was disease-free, class 1 was metastasis progression in 1 year follow-up. And initially there were 42 protein levels, so different proteins, and from them we would like to predict metastasis progression. So then we tested different algorithms, as Jorge was introducing. There here for many 20, 30 years, this has been this well known. There are many different ways of doing this kind of details, but we were testing minimal cost complexity planning algorithm, naive Bayes classifier, classification and regression trees, reduced error planning tree, decision trees, minimum error attribute for prediction algorithm, and logistic regression. And then we perform k-fold cross-validation, that this is very important in order to avoid what Jorge was introducing in the questions about overfitting. So this is really a very good solution to the overfitting problem. So this is the winning algorithm in what we did. This is called classification and regression tree. This is a decision tree, typically, and I'm going to explain you the meaning of that decision tree. So you have to take and see what if the tumor is in stage 1, then the predicted response would be 0. 0 is disease-free. So melanoma stage 1, no metastasis. In 184 cases, you do 46 incorrect cases. So then, if melanoma is in stage 2, you have to look to dermicidin. Dermicidin is a protein, and depending on the concentration in serum, you can go in one decision or another. So here, if dermicidin concentration was smaller than 2.9 micrograms per milliliter, then predicted response was 1, metastasis progression, 46 cases, only 5 were incorrect classified. And then if it's bigger than 2.9, predicted response is 0, and then from 41 cases, you have 3 incorrect classifications. So the total accuracy here is 80%, which is high accuracy in predicting metastasis progression. Then we continue this work using not only serum proteins, but also other classes of molecules I'm going to tell you now, and also some histological variants. So some of the patients here are the same as before, other are new patients, and we have in total 224 in stage 1 melanoma, 99 in stage 2 melanoma. From those, 20 converted to metastasis and 54 in stage 2 converted to metastasis. Melanoma locations were variant, and here I'm showing this, which is the Breslow thickness, which is a classical histological parameter that pathologists use for classify the aggressiveness of this class of tumors. So then our methods were to try to do the effect of cytokines, proteins, plus other serum proteins, histological, in particular the Breslow thickness, plus clinical variables for assessing prognosis. Class variable 1 was, again as before, disease-free. Class 1 was metastasis progression, and we performed supervised classification. So indeed, what we wanted to do is to find a subset of biomarkers which were good predictors for metastasis at early stages of melanoma, and we, as an output, would like to have a tentative relation between biomarkers that could be easily translated to the clinical practice. So for that, we took only a few subset of variables. Here, GM-CSF, interferon, and interleukins 4, 6, 10, and also dermicidin, as was shown in the previous article, a good prognostic value. Then feature selection was based on length weights of logistic rich regression model. This is a particular way of doing that. And then we were testing different algorithms as well, like logistic regression, support vector machine, decision tree, Gaussian naive Bayes classifier, and k-nearest neighbors vote algorithm. And again, k-fold cross-validation with 10 number of folds. So these are the results of the best classification we obtained. So here, accuracy of the classification can be measured based on different metrics. So precision recall are very well known. In the ROC curve analysis, people also use area under the curve, but there are other ways that are more specialized. But typically, the higher all these metrics are, the better classification. So here you can see how in red, in dots here, this is the classification you do only by looking to the Breslow thickness. So only by looking to the histology, this is your classification that we consider as a baseline classification. This is like our control to try to get better than that. So doing that, here this is an important thing, that by looking to serum cannot do better than Breslow in any of the metrics. But when we combine serum and Breslow, we even increase the predicting power that Breslow has, and this is called synergistic effect. And speaking about feature selection and what are the features more relevant in predicting metastatic response, as Jorge was saying as well. So we were obtaining interleukin-4, Breslow, and GM-CSF the most important features in predicting metastasis. So then we use logistic regression and raw curve analysis. I'm not going into detail, but this is very important way of getting cutoff values. Cutoff values have tremendous implications in clinic. It's just a number that is telling you that if your data is above or below that number, you are in one class or you are in another. So cutoff values have very good interpretability in clinical work. What you typically do is to represent true positive rate, also called sensitivity, as a function of false positive rate, also called 1 minus specificity. And you get this cutoff value that here, depending on 4 different variables: Breslow, GM-CSF, interleukin-4, and dermicidin. So if you have a new patient, given these 4 variables, you are going to calculate if you are above or below that threshold, and that has tremendous implications here in survival analysis. Kaplan-Meier estimator, you can see how when you have above the threshold, survival is significantly smaller as compared in the cases in you are below the threshold. So, and also here important the sign here positive, negative, positive, negative. The sign is telling you the contribution of each individual feature into the prognosis. So the higher the breast load, the higher the interleukin-4, the worse is the prognosis. The higher GM-CSF or dermicidin, the better is the prognosis. So to discuss this part, we have applied a machine learning methodology to find metastasis biomarkers in melanoma while keeping predictions fully generalizable. Inclusion of cytokine variables, interleukin-4, GM-CSF improves accuracy of baseline model, as explained before, the one corresponding to the breast load thickness classification for metastasis response in early stages melanoma patients. We have found multivariate cutoff to classify metastasis response from a ROC curve with area under the curve of 90%, which can be directly introduced in clinical routine. Furthermore, they found high accuracy of approximately 80% for metastasis response opens a window for immunotherapy applications in melanoma research. And I'm going to speak about the last case today. So this is machine learning, but in real world data. Okay. So I'm going to explain you why this means. So this has been done in collaboration with a company which is NeuronApp. NeuronApp is a online cognitive stimulation company, and for Spanish speakers is one of the world leading companies. So this is something that is now in revision in the Journal of Neuropsychology. So what we wanted to do here is 1 year prediction of cognitive decline following cognitive stimulation from real world data. So what real world data is? So it's just data that you are not collecting in any kind of a structure, especially in time. So in medicine in particular, a first definition could be data derived from a number of sources that are associated with outcomes in heterogeneous patient population in real-world settings, including but not limited to electronic health records, health insurance claims, and patient surveys. And here I'm adding more heterogeneity into the data. For instance, you could be getting data from any class of wearable setups or online patient evaluation metrics. So this is the modeling approach we did. So here you have typically many subjects, more than 80,000 or like that, and they do different training material in the computers. So typically you have in longitudinally you have many different scores of one person to different training materials. So what we did was to define in a range of time points like an average score, a score defined as truth, as time dedicated to the training material or activity, and the difficulty level that the activity has. Then based on that score, we would like to do is to try to predict 1 year after if that person would have cognitive decline or not. So to do that, we define it the difference S1 minus S0, and then do set scores and calculate here the patients that have set score smaller than media minus 1 sigma. In such a way, we define class 1 patients and class 0 patients. Class 1 cognitive decline, class 0 no cognitive decline. And what we would like to ask is, given a new set of values, so a new person is playing today, we calculate the number of truths in the activity, we calculate the time dedicated in the activity and the difficulty levels. We would like to predict cognitive decline at T1, which is 1 year after. Again, here, as a modelization, we are using raw curve analysis because of the cutoff values I was explained you before. So the methods: can real-world data predict cognitive decline after 1 year? Class variable 1, cognitive decline; 0, not having it. So predictors, possible features were 203 neuropsychological training materials, and they were grouped in 29 different categories. Logistic regression, classification, but we also were using others, but today here I'm going to explain you about these results. So we also were performing k-folds cross-validation with 5 different folds. So these are the results. Here we are using different domains, as you can see here. So in red line here is random classifier, so totally nonsense classifier. And then here in green, training data set and cross-validation accuracy for the test. This is more technical, but it's typically the green should be higher than the blue. But here what you can see is that the area under the curve is typically good in different domains. As you can see here, these are the results for the best classification. Then we asked it how these were changing when we were looking into populations that they have a common diagnosis. So when we look to the predicting response 1 year after cognitive decline in Alzheimer's patients, Parkinson, multiple sclerosis, or Down syndrome, we are getting that the same test could perform worse or better depending on the condition. So this is just to finalize my talk. I would like to give you some take-home message that I think is important after some years of working with this methodology in clinical work, and for this audience I think could help you to follow. So machine learning should complement the multiple analysis in health problems. Machine learning used as a black box, as Jorge was saying, might be sometimes dangerous. The expert opinion is critical to not reinvent the wheel. The transition from evidence-based medicine to real-world evidence has started, and also it will transform many fields in medicine, no questions about that. So this is the New England Journal of Medicine, which is a super high clinical journal, is already pointing out this problem, the pros and the cons of the real-world evidence, and how FDA and many clinical trials already are starting in these arenas. And this is just my personal opinion today. So this is for if you are doctors already, or if you are future doctors, consider this opinion. Medicine needs opening for engineers, mathematicians, and physicists. Beyond, consider these researchers as simple technicians, telling them what to do, because the way they think sometimes is what medicine really needs. Moving the observer outside the evidence that very often, not always, of course, that evidence is based on wrong assumptions. I'd like to thank funding in different agencies. 2 years ago, we got funding from the Brain Initiative, NIH. I would like to thank you, all of you, for your attention, and this is my email. I will be very happy to reply any questions or comments you would like to have. Thank you. Is there any comment, questions?
Hello. This was a very interesting talk, so thanks for that. I wanted to ask, because I didn't quite get what the role of artificial intelligence was in all these cases. So it was basically the machine learning was used as a statistical analysis.
Correct.
Okay.
Correct.
Okay, thank you very much.
Here, there is another question there.
Sorry, I'm going to speak Spanish porque lo tengo totalmente oxidado el inglés. La reflexión que hago es que es el problema que tenemos en medicina cuando queremos utilizar inteligencia artificial y machine learning. Es muy difícil conseguir datos masivos. Las Ns que has presentado son Ns muy buenas, excelentes, maravillosas, pero no son tan masivas para utilizar redes neuronales. En ningún momento ni siquiera lo has expresado porque es imposible.
No las usamos.
Entonces, claro, el problema, ya tenemos la tecnología, tenemos la gente, pero lo que más nos va a costar va a ser juntar los casos que tenemos aquí en el País Vasco, en Cataluña, en Madrid, en todos los sitios, para poder hacer unas bases masivas, para poder utilizar ya unos modelos más complejos.
Correcto, yo creo que eso es el cuello de botella, tener esos datos masivos etiquetados, vale oro es el problema de todo esto. Y luego también hay muchos ley de protección de datos, comités de éticas variados, que también, pues, en cierta forma, yo creo que el camino se hace el real world data. Vamos a tener que cambiar la forma de querer tener los datos representados y hacer con lo que haya, aunque esté recogido de forma altísimamente heterogénea.
So, good morning, and first of all, thank you very much, Dr. Cortes, for the masterclass in practical cases for machine learning. It has been wonderful. I would like to ask you, I'm deeply curious about the computational capacity that your research group needed in order to develop and perform these studies regarding machine learning. Thank you.
Okay, thank you. So, for most of the results I'm showing here, in a simple computer you can do it. You don't need clusters. For image processing, we work in neuroimage. Image processing is a very different scenario because you typically have 100, 200 people, and the pre-processing of the images you require high memory calculations, and for that we have a high parallel computing cluster, which is not huge, but you need at least 90 cores, cores like that, maybe 300 gigabytes RAM. For image processing is different, but machine learning in this laptop you can really do everything. There is another question there.
Yes, you have shown us that we currently have the technology in order to make assessments, but I would like to know in which current cases is machine learning underpinning real therapy actions? Because you said that it is not quite there yet, but perhaps there could be the possibility to use that in areas which there is no access to real doctors or qualified personnel. Therefore, I would like to know in which real cases is being applied currently, or you are currently supporting people doing those kind of actions.
Yeah, so I think as a support decisions help, like helping the clinician to make a decision, helping a machine to, for instance, in anesthesia technology, there is a lot of machine learning. They are giving you numbers of how deep is the anesthesia and this and that. All those kind of numbers are based on machine learning. They have different patents, are patented. So I think technology is using that for technology that clinical doctors use. as a support decision for clinical people in a private clinics could work as well, and in research is obviously, I mean, nowadays is really widely used.
If I'm not wrong, you are telling us that it is only nowadays present on productized setups. Okay.
In products, many of them have machine
private
learning
companies, products, can solutions. Okay, but is there not any public health initiatives that are currently?
Yeah, this is different because you typically do in research, you go for different papers, and then you publish articles. But then, how much of that knowledge go into the clinics? This is in a cycle. This is in a different stage, and takes different problems. I mean, I would say 2% of all these results finally go into the clinics. But I think this is a different problem.
Okay.
But if you are a clinical person and you like that, you could use it to improve your work. I think.
Okay, so you're telling us that currently we are only on the stage that you are only feeding the knowledge pipeline. That's your contribution. There are not real applications yet.
The applications are those numbers are good. You want to apply, you could, but if we are going to have an intelligent system putting here your skin and telling you what treatment you are going to use because of that, I think this is a different problem. Technology sometimes is there, but I mean, it has problems on other technology transfer, knowledge transfer. This is a different business, so it's not really my. Okay.
Thank you very much, Jesus.